Good evening and welcome back to number 5 of 5. This is our final part of the summer series. We want to thank our sponsors again, Southern Medical Association, Southern Medical Services, Warren Averett CPAs and Advisors, and the Jefferson County Medical Society. You have the same two clowns that you've had for the first 4 sessions tonight. Currently on the screen, myself, Maddox Casey, and my colleague, Say Evans. So just in the past, we've got a crowd that is rambunctious here tonight, so I'm going to settle them down real quick. But if you have any questions and you're not here in the loud crowd tonight, you can send us an email with a question to the email addresses on the screen. And those are there. So if this is your first time attending, welcome. And write down your email address and shoot us a question during the presentation. And if we have enough time at the end of the presentation, we will address your question. And if not, we'll be happy to email you back or call you back if you provide that information with the correct answer. So we've had enough time to write down the information. I'm going to scan back to our first screen. And tonight's topic is healthcare reform, a hot topic, and the cash flow related to healthcare reform. Our first slide talks about what we call the magnification effect of decreased collections. And simply put, the healthcare reform, as we've talked about in previous presentations, is causing a crunch on many practices. It's causing a crunch in decreased reimbursements as things begin to be bundled, as patients aren't able to pay. It's also causing a cash crunch as expenses continue to rise, and we've talked about the closing curtain effect and trying to open back up the curtain. But we want to illustrate here the effect to the bottom line for a physician, what it does to your actual pay, your take-home pay that you take with you when you have $100,000 in less collections, because we're seeing that across the board for many physicians. So if you currently have $1 million in collections and you collect in your operating expenses 50%, that'd be $500,000. That means available for you to take home is $500,000. That's illustrated in the first column. But if you have $100,000 less in collections, that's a 10% decrease in collections. That's very common in this day and age. But your operating expense stays the same. We can talk about controlling operating expense, but for the most part, if you can keep it the same or stagnant without growing, you're doing pretty well. So that's a 0% increase. What's left for you is $400,000. Now, as illustrated on the far right side with the percentage change, a 10% in decreased collections is a 20% decrease in pay for you, your take-home pay. And that's the magnification of decreased collections. Now, the same illustration below, we just want to show an illustration that if you have the higher your overhead, the more dramatic the effect of decreased collections are. So a 10% decrease, $100,000 in collections with a 75% overhead, $750,000 in operating expense. If your take-home pay was $250,000, well, now with the $100,000 less in collection, your take-home pay is $150,000. That's a 40% decrease in pay.
And that number available for a physician, that's going to include your salary, your retirement plan, your health insurance, any other benefits, life insurance, whatever else the practice is paying for you that benefits you, it's coming out of that $250,000 or $150,000 or whatever that number is. And as that amount decreases, if you're used to paying yourself a salary of $200,000 every year and then getting a $50,000 bonus at the end of the year in December, that's walking out the door with a decrease like this. So you're effectively losing your bonus in a situation like this, and maybe even more. Maybe you're going to have to reduce your salary that you're used to living off of every month.
Yep, that's exactly right. We did do a presentation on increasing practice profitability. If you can drive down your overhead or drive up your collections through one of the methods that Say and myself talked about, it would help in the current environment that we're in. But if you're not able to, this is the time to scale back, on your lifestyle, pay off your debts. We've been preaching pay off your debts for a long time, but get away from it so that when circumstances like this happen, you're in a position to continue to make your debt obligations and continue to practice medicine without going into bankruptcy. So hopefully you're not in that shape, but if you are, you can see the magnification and the reason to run a lean, efficient machine of a medical practice. So that's the magnification effect. Now we're going to jump into a little bit of the healthcare reform. So the healthcare reform, Affordable Care Act, PPACA, the Patient Protection Affordable Care Act, goes by many, many names. But the largest impact of medical practice is the patients and the patient's new insurance that they present in your medical office. And 3 quick points here. Deductibles and copays are increasing with commercial payers. If that's a shock to you, I'm sorry, you should have known all about that. But
you should have listened to our previous.
Should have listened to the previous 5 presentations, or listened to the news once in a while. But the level of coverage chosen from the insurance exchange can bring deductibles as high as $6,350. This is new charted territory for many patients and new charted territory for many medical practices. That is a very, very large deductible and a lot of responsibility on the patient. And now you have become the debt collector, and now you're responsible for collecting that money. And then lastly, age-based insurance. That's a side point. But basically, all insurance now is rated not on pre-existing condition. That was taken out of the Affordable Care Act, but on location and on age. So it doesn't matter what the existing condition was. It doesn't matter what they currently had. It doesn't matter about the utilization of the factor for that person. It's all based on their age. So if they were 26 and had high blood pressure and cholesterol and were using thousands of dollars worth of insurance, it doesn't matter anymore if is related to a 66-year-old person that's a Medicare. So let's say a 56-year-old person who was completely healthy, hadn't seen the doctor, hadn't had to go to the doctor other than normal checkups for the last 4 or 5 years. The 56-year-old's insurance is going to most likely be double what the 26-year-old insurance is, just because it's age-based. So as an example, and I know there's a lot of information on this page, this was taken actually from Blue Cross Blue Shield of Alabama. So if you're in a different state, it may not look exactly like this, but if you're in Alabama, these are our most common exchange products. As we've talked about previously, they're on metallic levels. So you can see platinum, gold, silver, and bronze. And as the metal decreases, the coverage decreases, but the premiums decrease accordingly. And what we want to show here is that you can see deductibles are going up. So $100 for an individual deductible, $200 for a family deductible under the Platinum plan. That's great. That would be a lot of medical practices. A lot of patients would be very happy with that type of coverage. But that's a very expensive type of coverage, and not many people have the Platinum coverage. It has great coverage, covered 100% for many, many items. Drugs are relatively cheap for that plan. But as you move down the metals, and let's just say from the groups that we've talked to, most people have either the gold plan, and I would say that would still not be most. I would say most people probably have the silver plan. With that silver plan, plan 1, plan 2, they're relatively the same. It carries a $3,000 individual deductible and a $6,000 family deductible. That is a large deductible that has to be paid before many of their items are covered. And if you look down on plan 1 under silver, under physician visits, this is another area. $30 physician copay for the first 3 illness-related office visits, therefore covered at 80%, subject to the calendar year, thereafter covered 80%, subject to the calendar year deductible. So they only get 3 visits, three illness visits for the whole year. And once they hit that, everything is only covered at 80%, subject to the calendar year deductible. So if they come see you on the 4th visit, they're going to pay full fee schedule rates as negotiated with your carrier. But still, we know many of those visits can be $180, $190 just for a well visit, or even for a sick visit. If it's surgery or some other related procedure, it's going to be a lot more than that. You can look down there at the outpatient surgery, covered at 80%, subject to the calendar year deductible, which means under Silver Plan 1, they've got to pay $3,000 for the individual before the insurance even kicks in. Which means you, the physician, the medical practice, is responsible. If the first place they stopped and they haven't paid any deductible, you're responsible for collecting that $3,000 from them. The insurance will not pay any of that. So the burden has shifted away from what we've seen in the many past years away from the insurance, on to the patient, and on to the medical practice. To illustrate an even more dramatic example, look at the bronze coverage. And the reason I bring up the bronze coverage is that many people, if they're not related to a group plan, are going to go to the exchange, have to purchase insurance, and they're going to premium shop just because they think they're healthy, they don't need insurance, just for a variety of reasons, or they can't afford the premiums under the better coverage, and they just need some type of insurance. And we think a lot of people are continuing to choose bronze coverage. And I think this will get worse as we move on and more people jump onto the exchange plans. You can see there, the individual deductible $63.50. They still get their 3 visits, $40, and then it's subject to 100% of the deductible. Surgery covered at 100%, subject to the deductible. Under the bronze plan, this is almost catastrophic coverage. Nothing's covered until you hit the deductible. So $63.50 or $12,700 for a family. Now on the second slide, this is just because we couldn't fit it all on the same page, but you can kind of see at the bottom some monthly premium examples. So let's talk about the bronze. So for the bronze coverage, let's take a family of 4, younger family with 2 children. They still have to pay $576 per month as a premium for the coverage we just talked about. So 576 times 12, let's say that's roughly $7,200 a year they're paying in premiums. And on top of that, as we just discussed, they have a family deductible of $12,700. So they could potentially be out of pocket almost $19,000, $20,000 before insurance even kicks in.
And if their employer decided to terminate their plan and this is their first time going out and getting health insurance on their own, they may not even understand any of this. They're not used to paying their premiums. Their employer may have paid all of it, so this is going to be a huge shock to those individuals. And when they visit you and find this out for the first time, they may be pretty upset, angry, and it's going to be up to you to explain that you had nothing to do with this. This wasn't your decision. You're just the one that's having to enforce these new rules and these new deductibles. And you're in the position of having to collect this from them.
Yeah, that's right. I mean, many people aren't going to understand what they're getting themselves into. They're just out premium shopping, price shopping, just like they would anywhere else, looking for something that satisfies insurance, but they're not really sure what they have. So Say's right on that. And you will become the enforcer, unfortunately. And we're going to talk a little bit about that later on, how to address that, how to make sure that we get every dollar we can as the medical practice. You can see here, and these slides will be released later on, but you can kind of see the premium examples. I mentioned the platinum coverage and how good a coverage it was, but you can see here that platinum coverage cost $1,100 a month. There are not a lot of families, and I would say not many at all, that can afford $1,100 a month in premium payments. They're just not going to be willing to pay that. That's not what they've seen in the past. So, and of course, you can see under the platinum as well, a family of 4, older family, then this would be somebody maybe, when I say older, I didn't say old, I said older. I think about in their early 50s with, let's say, some late teenage kids, their premiums are $1,500 a month. So that is a sticker shock for many, many people. They're going to move down the metals. The responsibility is going to fall in the medical practice. We've got to get good at collecting money and collecting it well if we want our bottom take-home pay to remain the same or grow. Our next slide shows as an example, if you're a business owner in Alabama, what you would get from Blue Cross. We talked about age-based insurance, and what they did is took their current plans, and Blue Cross in Alabama had plans such as 300 and 320, and if it had mental health, it was up in the 700 or 800 numbers, but basically mapped it to a plan. And here it's been highlighted, and you can read at the bottom, yellow highlight indicates the member level rates for the current MAP plan. So all they did was take what plan you had and mapped it over to a group plan. So a lot of employers have gone through this renewal process. July 1 was a big renewal date. So if you have a group plan and you're an employer, this is what you're going to get from the state. And you can see, just as a note about age-based insurance, look at the first line. You see the employee that's 61, the premium for gold is $800, and if they have a dependent that's 25, it's $283. So, and then you can see, of course, this is located in Huntsville, Alabama. So there are, you can see as their ages go up, the premiums go up accordingly. There's no other information here other than age and location, as we talked about. But for the older people, the 61-year-old on this plan right here, it's an expensive plan. This is a employee plus dependent. For the platinum, it's $1,286. Very, very expensive plan, and that's just two people on the plan would be that expensive. So there is going to be some premium shopping. We're just beating the horse to death talking about how high the premiums are. Inside of healthcare reform, there are some items that preventative care, essential benefits that are covered regardless of the deductible. So everything we just said about meeting the deductible does not count for preventative service. And that's highlighted at the bottom. This is true even if a patient has not met their annual deductible. And this is part of the Affordable Care Act. This is a good part, in my opinion, part that's going to be covered by insurance regardless. This allows for some of the services to be covered and is good for America to have some of these necessary services covered. I'm not going to talk about all of these, but I'm just going to briefly go through some of these. You need to know these as a physician. Your coder needs to know what these are, what services are going to be preventative when the patient shows up. Here you can see like colorectal screening, colonoscopy, that's covered under the adult services. Tobacco use screening, blood pressure screening. I mean, you can see the screen here. I'm not going to read them all out, but you need to know what you're going to get paid for from the insurance, regardless of what the kind of insurance the patient has. Services for women. There's a lot of services for women on here. If you're an OBGYN, there's a lot of services that are going to be related to you here. If you're a contraception, anemia screening, breastfeeding, comprehensive support, HIV screening. These are breast cancer mammography screenings. A lot of good things here that you need to know about for women. And then lastly, some services for children. These are the things that are covered: PKU screening, obesity screening, depression, autism. It's a whole list of them. You can usually find them on your state's insurance website. If you go to ours, if you go to Blue Cross, it would be there just because they're the large company in our state. But you can find what are preventative and what is covered. I will say, as a side note here for preventative services, what you need to be aware of and what is currently happening in some practices is people making appointments for preventative services and say, I'm coming in for my colorectal screening, and oh, by the way, we call that the oh, by the way symptom. They say, can you check this, this, and this while you're here? Well, you can, but you're not going to get paid for it. If you try to make that code and the patient, you may get paid for it, but the patient's going to have some responsibility. The best thing to do there is say, you're here for your colorectal screening. That's what we had your time slotted for. If you want to get something else done, that's fine, but you need to come back at a later time, make another appointment. And that way they understand that, this isn't, they're trying to link their free screening with some other stuff, their free preventative services with something they would have to pay for. And that's happening. They understand how to manipulate the system. And so you just need to be aware that you only need to do the services as preventative, as scheduled when they come in.
As Maddox said, depending on your specialty, you need to review that list, make sure make sure your staff know what those procedures are or what, everything on this list so that everyone's aware when it comes in and it's going to be billed correctly and you're going to get paid for that preventative care. Yep.
Here we've outlined some risk by specialty. We've often asked the question, well, I'm a ophthalmologist, what kind of risk do I have? So we thought this slide would be helpful for you to find your specialty, and this is our opinion. This is not published, certified. This is all our years' experience dumped in a bucket and spit out on how we think you're going to be affected by the Affordable Care Act. And I'm going to cover a couple of them and tell you why we think your risk is what it is. And let's look at ophthalmology. So ophthalmology, I made an assumed pay mix. C meaning commercial, M meaning Medicare or Medicaid. And then I assigned a risk and I made a comment. So for an ophthalmologist, if your risk is low, and the reason I think it's low is because most of your work is done under the government payers. Most of your work, and I say here, cataract, retina, is being paid by government payers, and they don't have these large deductibles. The patient's responsibility did not move very much. They probably still have $1 copay to see you. Now, that may not be true, let me just as a caveat, may not be true if you're an ophthalmologist and a lot of your patient base is not government payers. As a mid-range, if you see patients that are 30, 40, 50 years old, and that's a large base of your population, just on a preventative type services, you will have some risk. But as an overall statement, ophthalmologists, many of them are doing cataract surgeries, are seeing patients as they begin to lose their eyesight, and so their risk is low. From the OBGYN side, I'm just moving on the list here, we put it at a 50-50 pay mix, and we put the risk as moderate. There are many preventative services covered in OBGYN, as I mentioned earlier. You can look under adult services for for women, and you can see that many of the services that OBGYNs perform are going to be covered free, regardless of the deductible. But there are in Medicaid as well. If a lot of OBGYNs, especially if you're in a rural area, you probably have a large Medicaid-based population, and so you're not going to be dealing with the large deductibles. But on the other side, it could be moderate. If you're in an urban part, or if you're in a more affluent part of town, and you have a lot of commercial insurance patients, it's going to be a higher risk. It's also going to be a higher risk if you do a lot of surgeries. Especially surgeries related to those commercial carriers. That's going to change as well. Cardiology, we put at a 40-60 because of the fact it's 40% commercial, 60% Medicaid or Medicare. We put that at moderate risk, depending on what type of cardiologist you are. If you're individual, non-interventional cardiologist, depending if you do a lot of procedures or if you're just checking on old hearts. It will depend on your risk, but you get the gist here. The gist is, depending on what your payer mix is also going to dictate what your risk is. I would say, as a rule of thumb, the higher your commercial payers, your base, your payer mix is commercial, the more of a risk you run of not being paid. Just because it's now in the patient's hands, the better you have to be at collecting money. So that's a list. You can take it, study it, see if you agree. If you don't agree, send me an email. Let me know what you think. I'll be happy to change it.
But you're going to know your patient mix better than anyone else, or hopefully you do.
Yeah.
So you'll be able to assess this. This is just kind of a map for you to apply to your own practice and figure out where you think you fall in the risk category.
So now we move from healthcare reform, since we kind of set the stage talking about, the collection process, the cash flow, the revenue cycle. Everybody uses a little bit different term to talk about this. But we've set the stage to you need to amp this up. You need to retool this. You need to have a machine in place that's able to collect money. And so let's talk a little bit about the collection process and talk about 4 or 5 items here under reasons in the prior to service and after service, what it looks like. And the reason for getting copays prior to service, which is really the crux here. It's the most important part. So patient's motivation to pay. It's just like going to a nice restaurant. And let's talk a little about that. But patients are highly motivated to pay at the time of the visit. They've just seen you. Their services have been rendered. They've got it. They've done it. They're motivated to pay. So that's prior to service. They need the service done. They need to come. They're willing to pay the price. They're hurting, or they need some analysis done. That's why they're there to see you. After the service, they're less motivated to pay. It's like sending someone a bill 30 days later after they had a nice meal at a restaurant. They've lost that experience. They're less likely to pay.
Or they may be aggravated about something. They may not like the diagnosis. They may not like your nurse. They may not like you. You never know what it might be. So after service, there's a number of reasons they may not want to pay that weren't there before. So it's always good to get them to pay before.
Yep, that's right. So, I mean, the patient's motivation to pay prior and after service is dramatically different. The cost of statements, collecting prior to service reduces the need for these statements. So if we go ahead and get our full copay due by running an instant eligibility, which we've talked about in the past, we know what the patient owes us. We got the full copay or deductible payment at the time of service. We don't even need a statement. But if we need a statement, and because we didn't get the proper copay or we didn't collect the money and now we're provided the service, statements can cost $5 to $10. And I know that sounds high, but after the time you add up the postage for 1, 2, 3, 4 statements, depending on how often you send them up, the time to do the statement, the paper to produce the statement, and the staff, whether you're paying a billing company, a collection service, your own staff, to actually stuff those, send them out, deal with the collection of the money, reposting the money back on the patient's account, you've spent $5 to $10. It can add up quickly. So take that $5 to $10, multiply it by the number of patients that you see per day. If it's 20, 30, 40, and that's instant savings right there just by collecting the money prior to service.
And I think the days of sending paper statements are coming to an end. Everybody wants electronic, email, and that will be another way for you to try to collect after service. And there's a number of providers out there that offer that service, and a number of our clients have used those. So that's one option you may want to look into to just reduce your costs of trying to collect after service if you're sending a statement, is find one of those services that can do that securely through a client's email. That may be a good option for you to look into.
Yep, it's a great idea. The cost of staff, establishing prior to service, you can establish some payment plans, credit card on file, that's what CCOF stands for, or prepaid deposits, increases your cash and reduces your collection staff. Once we get after service, once it gets 60 days old, the likelihood is reduced to 30%. I would say it's probably, depending on your specialty, it could be even less than that. You've got the buyer's remorse. You've got to put the staff in place to make the reminder calls. You've got to hire a collection agency. The costs are adding up here as you move farther and further away from the patient visit. Collection agency cost, a given here. We've talked about that. But basically, by the time it gets to a collection agency, you might as well go ahead and write that off. Their ability to collect, only about a 15% chance of collecting that money. And if they do, they take usually 30 to 50% of that money. So you can go ahead and reduce the amount of money from your original visit. Let's say it's $100, and now you got a 15% chance of getting it, and then it's 30 to 50% from there. You're only getting about 7 cents on the dollar for everything you send to the collections agency. So it's adding up real quick and making a real good case for collecting your money prior to service. Collection rates, obvious here, collection rates are prior to service 75 to 100%, after service 25 to 70%. Every day it sits on our books is not being paid, is getting harder and harder to collect. There are other bills that are coming in place of our patients that they know they have to pay, their water bill, their electric bill, their car bill. You're about 4th or 5th, 6th, maybe even 7th or 8th down the list of getting paid, and if money's not there that month, it doesn't happen. So getting that money up front, again, we're going to beat it to death, talking about the importance of getting this money, how much of you could potentially earn more and how much you could negate the impact of the Affordable Care Act by just putting a simple collection process in place. So what is the best revenue cycle process? What is the best cash management? What is the best collection process? We're going to run through about 6 items here that we think are important to having a revenue cycle process. We started here. Any process must be supported by the physicians. And that's underlined for a reason, because if you, as the physician, don't support your own process, your whole staff will be demoralized. If you let them write off your friends from church or your lake buddy or your golfing buddy, and you let them pick and choose, and you say, no, I'm not going to pay for him, they're demoralized. You want to put a process in place that is consistent, that treats everyone the same, that incentivizes your staff, and we're going to talk about that, but it's got to be supported by the physicians. We say here it must be written as a guideline and a training document. Your staff needs training on collecting money. That may not have been in the past. You may have put Susie Q is collecting the money, and she may have been the sweetest person ever, and that might have let you fly for the last 5, 10, 15 years of practicing medicine. That's not going to fly anymore, just because we're giving up larger and larger amounts. If your copay used to be $30, $40, $50, and now you don't even have a copay, but it's subject to the deductible, like we just mentioned in some of these other plans, that $30, $40, $50 that you used to write off because it was just okay is now the full service. You're not even getting paid for what you're doing. So you've got to get the right people in the place. You've got to support it as a physician. You really need to train your people. We offer a training course where we come out and train for an hour and a half over lunch your staff on how to collect money in the proper way to do it. So let's talk about 6 points here. Number 1, appointment scheduling. The collection process starts right then, right when the scheduling happens. Thank you for making your appointment. You get your insurance card. If you can go ahead and send that to me, or your driver's license, please present both of those when you show up, for the visit. They need to be aware that all copays are due at the time of service, and that's being done right when they make their appointment. Thank you for making your appointment. You'll see Mr. Evans at 9:30 tomorrow morning or Thursday morning. Please be prepared to make your payment when you show up at the office. They know what their payment is most of the time. They've been to the doctor before. Patients with a balance should be transferred to the billing office. So if you do have patients that currently have a balance on the bill, they should know that whenever they make appointments. Your appointment staff at the front desk or wherever that appointment is in your back office should be able to pull up what's current on the patient's balance at any given time. If they have a balance, thank you, Mr. Smith, for making an appointment with Mr. Evans. I see that you have a current balance due of $60 from your last visit. We need to go ahead and collect on that money currently before you can make an appointment, with Mr. Evans. So at that point, your staff has to be trained on what to do, and they need to transfer them to the billing office. Your staff needs to have a method, a process, a document that they know what to do when people like that call in.
And it's a good chance to avoid the issue where a patient may show up and be ready for their appointment, they haven't paid their outstanding balance, and then you ask for payment, your front desk person asks for payment, and they're not willing to pay, and then you're having to, your front desk person has to tell them, well, you need to make another appointment at another time after you can pay. And they say, well, you're denying me medical care. I mean, this is the best opportunity to avoid a confrontation or an issue like that at your front desk.
Yep, that's right. Everybody's about expectations, and just putting the expectation that they're going to have to pay, keeping that consistent, and making it happen for every single patient it will work wonders in your medical practice. So copay deductible collection, verify coverage and copay by electronic eligibility. This, we think, is a very, very, very important part of running a well-oiled machine of collecting money, because electronic eligibility is the only way you're going to know what that patient owes. That can come with your practice management system. It can come also by just logging into the insurance system. But you need to be able to tell Mr. Smith when he walks in that today your copay is $50, not be asking him, what's your copay? Because they usually don't know, especially males. Males usually don't know what their copays are. And they'll just give you some random number that it was 10 years ago. It's $20, I think, sir. No, it's not $20. Your copay is now up to $75. Or, under worst case scenario, you've already used all your copays, and unfortunately, you're going to have to go ahead and put up $150 to see the physician today.
Yeah, if your practice management system can't currently test the eligibility in the beginning, or tell you what that deductible, that copay is, you need to get a price on what it would cost to upgrade your system so you can be able to do that, because that's a very valuable tool that really should. Every practice needs to have that.
Yep. Be prepared to reschedule the visit if the patient cannot pay. This is part of the training for the staff. Thank you. I understand that you had 3 bills this month, and the power and the water bill keeps coming every month. But unfortunately, Dr. Evans cannot continue to, see patients without payment being paid. This is our process. This is our standard. We'll be happy to reschedule the visit for you. Collect any balances. We talked about that. Anything that's outstanding needs to be go ahead and have being paid. And then lastly, if you have the resources to engage a financial counselor, if you have someone on your staff that can act as the financial counselor, I understand your concerns, Mr. Smith, I'll let you talk to Betty. She's our financial counselor. She'll meet you back at this room, if you can designate a room, or this window, and she can help you. At that point, the financial counselor, if that's their only job, that you can begin to talk about, hey, we can put you on a payment plan, we can put you on a credit card on file, we've got to get some payments, and this is why. Procedure scheduling. Procedures, as we talked about, can be a lot more costly. You're not just giving up your EMM, your code for an office visit. Procedures could be a $2,000 or $3,000 thing, and under some of these plans, procedures are not covered until you hit the deductible. So policies have got to be reviewed. Hopefully you're doing this already to estimate the out-of-pocket expense. We're saying that at least 50% of the estimation should be paid prior to scheduling. That would, because you're booking, you're prepping, depending on your specialty, a whole room, a whole block of time for someone to have a procedure. This is just like reserving a spot somewhere where you have to put a down payment or a credit or a deposit. You're holding a spot. This is you're the physician. You should be paid. And if they book out your whole morning and don't show up or can't pay, you basically just work for free for the whole morning. So payment plan should draft a credit card and no promissory notes. If they're going to make a payment plan, we need to get them on a credit card. There are some rules here. You don't want to become a lender. You do have some issues with making sure the credit card information is encrypted. That's a whole other subject, but there are services that do this for you, draft it automatically for you. It does cost you a little bit of money, but in the long run, the patients are on a plan, making the payment, and you're actually able to collect the money. If it does get to checkout and you haven't received any money, this is your final opportunity to collect that money before they walk out the door. It's the time where they have the least buyer's remorse. They've just been serviced. They're face-to-face with you. You need to have the right person at your checkout who understands the need to collect the money. They may even be incentivized to collect the money, but with hand-on prescription, not that we're going to withhold it, but hand-on prescription or the appointment card. Mr. Smith, you owe $50 today for your visit. How would you like to pay? Not will you pay, but how would you like to pay today? We take check, cash, credit card, cattle, whatever you have is bargaining power. That's for the checkout. If it gets past the checkout, we just already mentioned, once we move past the checkout, it's buyer's remorse. The collection percentages go way down. You're most likely not going to get that money from the patient. So number 5, billing. There are some little tricks here, but sending statements, weekly cycle billing, and that might be a little too much, might cost you a little too much money. Some people like to do it on the 15th and the 30th of the month, send the bill out on those days because that's when a lot of people are paid and they have the money to pay the bill, and maybe your bill will make it toward the top. There is some leniency here, hardship policies for those patients who cannot pay. We prefer to have that through an application process, not just anybody who says they can't pay, because everybody would say that, and they catch on quickly. Believe me, it spreads like wildfire once you let somebody off the hook. They let everybody know in their family, immediate family, community. The word of mouth can work for you and against you if you say that you're not going to collect payment. Effective staff training, we talked about that. Your staff has got to be trained. This is new to the medical profession. The training is necessary, is vital to running your practice correctly. They need to know how to collect money. They need to know when to collect money. They need to know how much money. It's just as important and is going to play a bigger part in practices as we see more patients with larger deductibles moving forward in this environment. Billing, reduce the denials and days in AR. This is a given, but basically any claims that have been denied, we need to have somebody working those. We need to know what our days in AR, we need to know what our goal for our days in AR are. And, rule of thumb here, 25, 30 days, pretty good days in AR. You're getting up into 45 or 50, something's not right. You need to have somebody come in, look at it, determine what's going on with your AR. Accurate documentation and coding. This is just as kind of a side point of the revenue cycle process, but we're trying to get you to a point of collecting the most amount of dollars for the services you're providing. You've got to have the right documentation because there are obvious risks for not having the right documentation. And of course, if you're coding, undercoding, or overcoding for what you're doing, those both run large risk. Undercoding, not receiving enough money, and overcoding, the risk of having that money taken back from an insurance carrier or even from a RAC audit, a government carrier. Those are prevalent. As the healthcare budget stays where it is, they will find ways to siphon money out of physicians because they think that physicians are overpaid. So those are not going to go away anytime soon. So documentation and coding are an important process to your revenue cycle. Collections, reduce statements about time of service. We talked about that. And if you don't have to send out statements if you get the money up front. Payment plans, credit card on file. This is the new thing in medical practices. When you check into a hotel, you check into the Days Inn, the Motel 6, the local hotel. Your people don't have a problem giving the $8 to $9 to $10 attendant at the front desk their credit card. They never worry about that. But for some reason, when they show up to their medical practice, a professional run establishment with a professional running it, with highly trained staff people, they're a little bit iffy about handing over their credit card to have it on file for their services. You got to begin to change that morale, and it's changing currently with the system we're under. But they got to be used to or get used to having that credit card on file, and that'll help your collection process. Collection agency with a better than a 15% collection rate. A lot of those collection agencies, hopefully you're paying by the amount of money that they actually recoup for you. If you're not, you need to get away from whatever you're paying. But find an agency that's actually effective, legitimate, and can actually collect your money in an effective manner. And those do exist, if we get there. What else is needed to deal with changes in healthcare? Your practice has to be operationally sound. This is a changing environment. Things are going on. These are about 4 things right here that we think operationally, these are just little gimmies, would run your practice more efficient, effective, ultimately making you more money at the end of the day. Paper processes and utilizing technology to perform tasks. This is the big push. This has been the push for many, many years. EMR, we all know, electronic medical records. They are a pain in the neck. It's a pain in the neck to get up on one, to implement one, to use one. But it does utilizing that technology, once you get through the first couple months or 6 months, the hardships, it will free up some of your staff. It could free up some of your payroll that you're currently paying, your overhead. It also allows you to bill more effectively, especially as we move closer and closer to ICD-10. I know that's still way back in the checklist for many, many people, but that's only about a year and 3 months away. We're going to move quick to that. You're going to almost have to have an EMR in order to survive in that environment. You might as well go ahead and bite the bullet for that. Electronic eligibility, that's another piece of technology that's critical to using. Your accounting software, your deposits, your remote deposits, that's almost a given to keep someone from going to the bank every single day, but to be able to run those remote deposits. We're getting more and more savvy. Patient portals, patient kiosk, any way you can use technology to be your friend. It's out there. There are people, I know you see vendors selling you left and right. There's some of those things are awesome, some are just okay. But using technology to free up some of your staff will be important as we move forward in healthcare. Effective operations reduce staff and aid in cutting costs. We gave a whole seminar on the effective operations, but staff is often your biggest number. Anytime you can reduce a full-time staff, it's an easy way to open up that curtain, easy way to put more money in your pocket. But if you don't have the right operational procedures in place, it's going to be tough to do that. If you got people running around doing the wrong things, not being effective, not being efficient, your practice is not going to deal with the healthcare environment well at all. Operational process promotes quality and patient satisfaction. Quality and patient satisfaction is where we're going next. I would tell you that we've been on fee-for-service, how many patients you can push through, how many procedures you can perform for many, many years, but the quality and patient satisfaction is making a very, very big push. I think we all know that we'll be there soon. You've seen the recent implementation of patient-centered medical homes by allowing more quality care. You could get a potential increase to your pay of 30%. A couple of years ago, we saw by adding generic drugs into it, you would get and patient satisfaction. You could potentially get an increase to your reimbursement. But as we move forward, current administration is going to promote quality. We've talked about that in the past. We talked about PQRS reporting system. Your EMR has got to be able to pull out meaningful use. We're going to start moving toward that. Your satisfaction scores, your patients can already rate you on different insurance. It's all going to play a part. It's going to be a little bit different than in the past, but it is going to come with incentives. If you can do quality care and have great patient satisfaction, it's going to push up your bottom line. Just the bottom point, higher revenue, more efficient, more productive. That's a given. I'm not going to go any farther on that. Increase staff performance, getting the most out of your staff, set some goals for them, define some processes, track performance, and incentivize performance. This is operations 101, but you got to set some goals for them. They got to know expectations. They've got to know what you expect of them. You need to define the processes for them. What kind of processes do you currently have in place? This is anything from how do we collect money to how do we take our breaks to how do we get paid. But those need to be defined. If you don't have a current handbook in place, if you don't have current HIPAA training in place, they've got to know their processes. And then you've got to track that performance. Come up with a mechanism, incentivize your manager to come up with a mechanism to track their performance, and then incentivize those who perform well. Incentivize them with pay, incentivize them with benefits, incentivize them with extra time off, incentivize them with bigger parties. You can go big, you can go small, but getting your staff to perform at the highest, most efficient level does nothing more than drive to the bottom line. Oftentimes, we get accused of practices. I can accuse them of tripping over dollars to pick up pennies. They're looking at the wrong places. You need to work on your staff. You need to spend a little bit of money here to get them trained properly. And we can talk about the best run organizations in the world. We can talk about the Disneys. We can talk about the Southwest Airlines. We can talk about Starbucks. I know those aren't medical practices, but in the future, you're going to be set with the same standards. The highest, best medical practices are going to be those with the best run staff. And I know that takes away from the quality of medicine, but it's going to be true as we move forward and as the regulations begin to mount even more than what they are now. Quality, know what your top payers expect. We wrote Blue Cross by specialty here. If you're in Alabama, that is going to be probably your top payer. If you have a lot of commercials, you got to know what they want. What are their quality measures? Participate in quality measurement. Connecting with specialty organizations for assistance in promoting the concept of physician and the staff. So you've got to get on the quality train at some point. It's just a matter of when you get there. You might as well go ahead and bite the bullet now. Patient satisfaction, I briefly mentioned patient satisfaction, but take some responsibility here and learn what your patients think. Whether that's a survey when they check out, a survey in the waiting room. Ask them, how was your visit today? I mean, these are the things the top run organizations in the world do. Your staff may need to be trained on this, but Disney does this, Southwest does this. Their people are invested in their company, and at the end of the day, it promotes patient satisfaction. Prepare an action plan if you don't have good satisfaction ratings. What are we going to do next? How are we going to improve this? Are we going to put Wi-Fi in the waiting room? And just little things like that. We're going to put a TV out here. Are we going to move them from one waiting room to a holding waiting room so that they don't think they're waiting for 45 minutes, but rather 20 and 25 minutes in two waiting rooms? Those are the type of things that you need to be thinking about as we move forward, and patient satisfaction is going to be critical to your reimbursements. Monitor satisfaction, continuous surveys. You don't know how you're doing until you ask. And then promote satisfaction with the staff. And we say physicians, we're talking about you. Our staff can be big, important promoters of satisfaction with our patients, and we've got to get them on that same page. That is it. That is all we have for our healthcare reform and cash management, cash revenue cycle talks for tonight, kind of a collection speech we just talked about. Say, do you have any questions submitted to you on your phone?
Let me check.
Let's see, I do have one question submitted here right now. And the question is, hold on. Maddox, can you talk about the penalties associated with healthcare reform and how that will impact medical practices? I can. Quickly, as an employer, medical practice, you are lumped in just like any other business. The penalties currently right now, called the employer mandate or the pay for play, are effective if you have 50 or more full-time employees. Full-time employees is defined by working 30 or more hours per week, and that goes into effect for over 50 in 2016. Now there is a bubble, 2015, sorry, but there is a bubble provision in there for anybody between 50 and 99 full-time employees. That doesn't take place until 2016. So a 1-year provision for anybody who falls from 50 to 99. So if you have more than that people, you have to offer insurance. And I know this is on a sidetrack here, but if you're a medical practice, you are an employer. If you don't offer insurance, then you will be subject to a penalty. That penalty will be $3,000 per full-time employee. Sorry, $2,000 per full-time employee over 30. So if you had 70 people, that's 40.
And that's 30, the number of employees, not their age.
Right. Not their age, number of people. So if you had 70 full-time people, as defined, like we talked about earlier, over 30 hours, you had 40 over the limit. 40 times 2 would be an $80,000 penalty. That penalty is non-deductible. That would be your penalty for not offering insurance. Now, on the other side of that, if you do decide to offer insurance, it has to meet 2 criteria. And this is a little complicated, and I don't have a slide to talk about it, but I can, for the person who asked me, I can send it to you. It has to meet 2 criteria. The insurance has to be at least meet the minimum requirements, essential coverage, which is 60% of an actuarial determined value. All of those plans that you saw just a second ago, bronze, silver, and platinum and gold, all meet that. Most plans will meet the 60% value. If it meets that, second part of the Act, Affordable Care Act, it has to be affordable, which basically means the premiums that your employee pays out of pocket cannot exceed 9.5% of their household income. So the premiums out of their pocket cannot exceed 9.5% of their income. If it does exceed 9.5% of their household income and they go to the exchange and they buy a product, they will get a subsidy of some type, most likely, but you will pay a penalty of $3,000 per person that goes to the exchange, not to exceed the first calculation I gave you. So as a quick example in your head, if you had 70 people and you decided you're going to offer insurance, and let's say 30 of them went to the exchange and qualified because you had a very low income staff, that would be 30 times $3,000. That's $90,000 in a penalty, but it cannot exceed the first calculation I gave you, which was 40,000 times 2,000, which is an $80,000 penalty. So you wouldn't pay 90, you would pay $80,000. So that's basically a whole presentation in itself. I'm talking about the pay or play, but that's how the penalties work. You don't get away from that from being a medical practice. It's not affecting many medical practices because most medical practices don't have 50 full-time people. I think we only have a couple, 3 or 4 or 5, that employ more than 50 people on a full-time basis. But what that is doing is it is pushing some people, since they have to offer insurance, they're going into exchange, which ties into this presentation by saying a lot of people are going to have exchange products at the end of the day, and they're going to show up in your medical practices with a bronze or a silver or a gold plan, and you have to be ready to collect that money. That is the only question I have. So that will wrap up number 5, of our series. We appreciate the time. We appreciate Southern Medical Association, Southern Medical Services, Warren Averett CPAs and Advisors, and Jefferson County Medical Society. We appreciate the time, sponsorships. We hope this has been helpful for our summer series, and we look forward to getting back with you. If you have any questions in the meantime, if anything arises, let us know. You have our email addresses on these presentations. We'll be happy to come with you, sit down and talk with you, help your practice become more profitable, help you become more profitable as a physician, navigate healthcare reform, talk about the buy or sell in medical practice. Those are some of the topics we've covered here. We'll be happy to talk anything A to Z with you on your medical practice. We appreciate your time tonight. Have a great night.